Ladies and gentlemen, welcome to today's Supportive Care Coalition webinar. Today's presentation is titled Palliative Care in the Pandemic, Challenges and Lessons Learned at a Catholic Hospital, presented by Dr. Natalie Rodden. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. You will be receiving an email tomorrow with access to the recording to listen to on demand. A large portion of today's webinar will be a question and answer period, so please use the questions panel on the right side of your screen to begin submitting questions at any time for our speaker to discuss. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you, Brianne, and welcome everyone to today's Supportive Care Coalition webinar. For those of you learning about the Supportive Care Coalition for the first time, the coalition is a partnership of Catholic healthcare ministries from across the U.S. dedicated to advancing excellence in palliative care through ongoing advocacy efforts at the local and national levels, interprofessional education, resources in healthcare ethics, and the integration of spirituality in palliative care practice. Coalition members have complimentary access to monthly webinars, numerous resources on our website, and a community of like-minded learners from all disciplines represented in palliative care. Today, we are excited to continue our new series, Navigating New Realities, Best Practices in Palliative Care During COVID-19. This best practice series highlights palliative care clinicians across the U.S. navigating the new situations and issues that have arisen in healthcare in light of the pandemic. These sessions will spend about 30 minutes or so discussing new challenges faced in palliative care, solutions that worked well, and key takeaways, followed by an extended period of question and answer. As Brianne mentioned, you can begin typing in your questions for our presenter at any time during today's presentation. So I would like to welcome Dr. Natalie Rodden. Dr. Rodden is a palliative medicine physician and currently leads the palliative medicine inpatient consultation service at St. Anthony North Health Campus in Westminster, Colorado. In addition, she helps oversee the hospital's ethics committee and provides education to medical trainees. Also, in her spare time, Dr. Rodden is currently pursuing a master's degree in bioethics and travels around the United States providing education and advocacy about palliative medicine and end-of-life ethical issues. And so, Dr. Rodden, welcome. Thank you so much for joining us today, and I will turn it over to you.
Good morning, everyone, or good afternoon, depending on your time zone. Thank you, Denise and Brianne. It's a real privilege to be here today. I would like to start this webinar with a prayer, so if you would please join me. In the name of the Father, and of the Son, and of the Holy Spirit. Lord, we ask you to be with us during this challenging time of pandemic. Please be with our patients and their families. Particularly be with those struggling with isolation, despair, fears, and loneliness. Be with our colleagues in healthcare. We ask you to guide our healthcare and government leaders. We are so grateful for the tools you have provided us and the gifts you have given us to serve and to help others. Please give us your strength, peace, and consolation as we continue to support and love the vulnerable. Please be with me as I share during this webinar, and may the information and discussion prove fruitful for listeners. We ask this in your name. Amen. Father, the Son, and the Holy Spirit. And so to start, I'm just going to give a little introduction to the work I do. Like Denise stated, I work in the North Metro Denver area. I've been at St. Anthony North Health Campus for 4 years. I moved here directly after finishing my palliative medicine fellowship, and our team consists of myself, a dedicated social worker, and we have chaplains rotate with us from our chaplaincy residency program. So we're small. We have about 110 patient beds in our hospital, but we're part of a 17 hospital system, and we're very happy that we have one of the highest palliative care penetration rates in our system. We have very good relationships with our intensive care doctors, a lot of our subspecialists. We also have a family medicine residency program that sends learners to work with us. So our team is quite robust and has a pretty good involvement here in the hospital. And particularly during the last few months, we have been very, very busy. And I know that this webinar might be hitting palliative care teams at different places in where their state and local area is in the setting of COVID-19. For us, we hit a peak in late April, early May, and we're starting to see a few more COVID-19 patients again in the hospital in the last couple of weeks. In other places, I know you may be in the middle of a peak surge of cases. In some places, you may never have had a strong surge. And so I hope that this webinar today can provide some relevant information to everyone, no matter where you've been, and to tie together the importance of palliative care during this very difficult time in healthcare. And so for my team, our workload about tripled from February to April, and we were almost on every case in the ICU, every patient, COVID or non-COVID, during this difficult time, because I think that a lot of our consulting providers realized the struggles, the additional stress on patients and their families that this unique time presented. And so they knew that an additional layer of support and help to these families and patients was going to be very helpful. And so for those of you who may not be in the trenches of patient care, so to speak, who are on this webinar with us, I hope that this talk today will give you an insight into what it was like a bit behind the curtain of doing palliative care and being in the hospital during this time. So, and just for those who are numbers people, we have had between 100 and 200 COVID admissions at my hospital this year, and we've had between 10 and 20 deaths associated with COVID at my hospital. And when I got these numbers, I'll admit to you, I was very surprised at how low they were, and especially the death number. And I think that was because the emotional gravity of these cases and how difficult they were for our team. And we're an acute care hospital, so our length of stay is not that long typically, but these patients were staying here, over a month sometimes on the ventilator, and working with the families over the course of that time, and just the heaviness and the difficulty of some of these cases made it feel like there were many more. So just something to say, like it felt a lot harder than the numbers might show. So I'm going to split this up by talking about the challenges and the lessons learned and the things that I've worked to improve care, both from a medical perspective and from a personal perspective, because I think it's important to acknowledge both as we think about our sustainability and continuing to provide the best care for the long term, and who knows how long this difficult period will last. And so I'll tell you that at the beginning, I think many I spoke to, was kind of in denial about this happening. And I'll tell you that if I had myself a year ago look forward to what kind of care I would be giving, what it would be looking like these last few months, I would have said, what dystopian world are you living in? This is not why you went to medical school, Natalie. This is not the medicine that you agreed to practice. And all these challenges that I'm having to deal with now is really not what I think many of us ever wanted to see. And it's very difficult. It goes against the instincts of palliative care, of our patient-centered advocacy for these difficult situations. And there's such a stigma. I talked to a colleague who had cared for patients during the AIDS epidemic, and she compared this to that period as what she could best recall, and how difficult it is trying to connect and love these patients when there's so many restrictions to being able to reach them. And so these patients are in such isolation. In my hospital, the patients with COVID-19 were restricted and continue to be restricted pretty much to one doctor visiting a day. Usually that's the intensivist or the hospitalist on their care team, and then their bedside nurse. So as a consultant, and me and my colleagues, we weren't allowed to really go into the rooms. They wanted to really restrict the exposure to the patients, and I understand that. It's just really hard when my baseline is sitting at a patient's bedside, holding their hand, looking into their eyes, giving a hug to their family members. And so my team had to be very creative about how to connect when we couldn't actually be with patients. And then we think about the isolation they had from their loved ones. For many weeks, we were allowed to have no visitors in the hospital, period. There were a few exceptions around beginning of life and end of life, but for the majority, none of our patients could have any visitors. And if you think about the palliative care patients we serve, people receiving new diagnoses, people with dementias, people with so many additional struggles and barriers, maybe to their comprehension of their healthcare situation, this is very, very hard. And then we have our patients with COVID-19 who are stuck in their rooms with no ability to be in touch with their loved ones. The chaplains weren't able to go in the rooms. There was a period where we were struggling getting priests to come into the hospital. And of course, in our work in palliative medicine, the fear was these people were going to be dying alone. And how horrible is that? I remember one day near the beginning where we had these extended long periods of getting COVID-19 tests back, where we would have maybe a 2-week period before a test would come back if it was positive. So we'd have these pending patients where we were treating like they were infected. And some of these patients, we had 2 in one day that were nearing death. And so the family members are very scared to even come in. And I remember my social worker, she just sat and was at vigil, basically, at a patient's bed at the door. And she wasn't able to go in, but she could watch them in their bed. And it was just agonizing to us. It was agonizing to the nursing staff. I remember calling an ethics meeting just to talk about it with our hospital administration. It was super hard to be able to see this and to figure out what battles to fight and where to start when there were so many barriers and struggles that we were seeing. And then a lot of what we did was trying to support the family members, over the phone and be in touch with them on virtual communication. And the layers of anxiety and fear and anger, even guilt, if they felt that they gave the disease to their loved one who is now here in our ICU. That was an added layer of complexity that I hadn't seen in other types of disease states that I've cared for in the past in palliative medicine. And so it was very hard. It was very emotionally challenging for our team. We would work with families who would tell us that no doctor had called them in the last 10 days. So I realized that there was a big gap in communication. And because people weren't allowed to visit their loved ones, they stopped trusting us. There was this lack of trust. They weren't seeing what we were doing every day. They were getting limited updates, if at all, at times. And they weren't sure what to believe or what to know. And a lot of the families of our patients with COVID-19, they had been rather naive or new to the healthcare system, like they weren't chronically ill. They had been functional, healthy people in society who were now struck with this horrible illness, and they weren't used to how the hospital culture works and what they should expect. And I had to tell families, you need to expect to get communication from your doctors. You need to expect to get updates. So there were all these limitations. And I'll tell you that so many people were unfamiliar with what a ventilator was. And so I would try to paint a picture of what their loved one was looking like in the ICU. I remember distinctly I had a family of a patient who had been prone on the ventilator for a period of 2 weeks, and very, very sick in our ICU and often on pressors. And anyway, the family tells me when I ask them what they understand about their loved one, they say, oh, she's stable and she's more comfortable on her belly. And I think that was because the nurse had maybe told them that from like the previous shift to this shift, she was stable and that she was in a position that was comfortable in a prone position based on comparing that to being on her back. I don't know. But as you know, this happens a lot in palliative medicine where families understand something very different than what we know as doctors or the medical team. And so that was very emotionally challenging to try to break through and not to appear like the bad guys as the palliative care team, sort of telling them what was going on in a realistic and truthful way. But for many families, it was like dropping a bomb. And so it was super hard, and it continues to be as we continue to struggle and grapple with these difficulties. And I think on a personal level, you can imagine how this impacts you too, because it's so different than what we're used to. I saw this graph and I feel it's very relevant. So on the left, we're thinking about the emotional highs versus lows. And on the bottom axis, we're looking at time. And so for me, my emotional state sort of mirrored this. I think initially I was, like I mentioned, rather in sort of a shock or denial or really not understanding what was happening. And then as I realized what was going on, I thought, palliative care is made for this. I'm equipped with special education in difficult communication and crisis management. My team is really good at working with challenging family dynamics and difficult diagnoses, and we're really equipped to help with symptom management. And so for a couple of weeks, I was so busy. I was getting on all of these different patient teams to help them, and it was the most satisfying I'd felt in a long time. I felt this is what I'm made for. This is where I'm here to help. And then over time, that intensity that I felt was sort of overwhelmed by this compassion fatigue, where I felt that I wasn't making much of an impact. We were having a lot of challenging interactions with families because of the reasons I mentioned before, and I started to become more disillusioned, like the graph says. And then over time, I had to realize what I needed to do to help make the system better at work, and how we were working as a palliative team, and what I was doing personally to not be so drained and to be able to have sustainability to keep doing this. And so I think I'm in this reconstruction period, but we'll continue to see. Time will tell. And so sometimes I did feel like this puppy, honestly, because it's so challenging personally. I think normally I'm pretty good, and many of us that work in palliative medicine, we're probably pretty good about leaving work at work. I have a very active social life. I'm very extroverted personality. And so with COVID, it was really different because I couldn't leave work at work. Even though I was fortunate not to be struck with the disease myself, my personal life and my world were still greatly affected by COVID-19. And everyone wanted to talk about it. And it's all over the news. And so I couldn't really escape it. And so my work-life boundaries, which I usually work very hard to maintain, got kind of messy and got kind of fluid. And it was also difficult to take a day off. I try to take frequent breaks or take little trips. All these things I had planned. I had a personal retreat planned, some talks I was giving. All these things I was looking forward to were just getting canceled. And so it was thing after thing. I think we all have had things in our lives get canceled we were looking forward to, and a lot of milestones for people and events, and it's very sad. And so I think that was tough. And then because of this, hero mentality that we see so much in the healthcare industry right now, or the media, I think I felt bad. I felt like I couldn't take a day off. I was so needed, I felt, at the hospital, that I wouldn't let myself take a vacation or even one day as a break. And I'm the only palliative doctor at my hospital, so I worked basically from beginning of March through mid-May without taking a day off, and that really started to wear on me. And I think when I did take a Friday off in mid-May, it was my birthday, and that honestly was a turning point for me to start feeling more rejuvenated again, and I got out of town a little bit, and I realized how important that was for me. Because there was a real sense of isolation that I felt. So I live alone, and even though I was coming to work and being around people at work, which was sort of normal, it's like working like normal, outside of work, I pretty much put myself on a strict quarantine or isolation because I didn't want to bring anything from the hospital home or from the home to the hospital from any friends. I couldn't bear the idea of getting someone else sick, and sort of martyred myself to say, I'm not going to see anybody. And that was very, very bad. And I think I had this sense of self-reliance that truly was to my detriment, because I wasn't asking others for help. I wasn't seeking support. I wasn't making sure that I had ways to refuel myself. Because all the normal things like events that I would attend, or going to mass, or being with others there, taking trips, hosting parties. I love hosting parties. And I couldn't do any of these things. And so it was like work got harder and all my coping mechanisms got depleted. And so, of course, that's a recipe for disaster. And so through all this, it was just morally distressing. It was really hard, and I felt like I wasn't making a lot of impact. I found myself crying more frequently. I found myself withdrawing. I honestly almost thought about starting an antidepressant, because I knew this was situational, but at the same time, I was not doing well. And I could see myself having like a shorter fuse at work too. And that was, no one needed to realize that. And so it was very evident to me that things needed to change. And so I had to be really creative about what could be better at work and what could be better outside of work. And I think we all can kind of probably resonate with that, because we have to be able to keep doing our job and people need us, yet we have to be able to be healthy and whole. And so how I attack things at work, we're really thinking about what palliative care does best, because there's so many ways we can truly shine during this difficult time. Very early on, I made my presence known to the hospital leadership. So I reached out to our chief medical officer. I reached out to our ICU lead, the head of our hospitalist group and family medicine department. And I said, listen, this is challenging. We're here to help. I'm here to help with taking residents on if they have rotations that are canceled. I'm here to help with difficult conversations in the ICU. I'm here to help with whatever I can. I'm here to help on a system level. I contacted our hospital system CEO and just said, this is so hard. I'm praying for you. If you need help, I'm a little measly palliative doctor at this little hospital, but if there's anything I can do, I want to be available. And, I think that was very good early on, because sometimes people weren't thinking outside the box and they were able to say, oh yeah, there's palliative care. How can they help? And to really let our value be known, because what we could do in the hospital for patient advocacy, for helping to destigmatize what was going on, was huge. And so I worked with our chaplains to help create a protocol that anyone who came in with a high degree of risk for decompensation from COVID-19, we would get advanced directives very early on to make preparedness plans for them. We would help with calling families early. We'd have meetings with the patient even in the room with us. They would be in the room, we'd have the family on the phone, get everyone connected. I think that we were able to just show how beneficial we were. And I think as palliative care teams, sometimes we worry that we're on the chopping block, that if hospitals are losing money during this time, then maybe we're lost. But to say to my leadership team, hey, I'm on all these patients and our workload is triple and we're really helping a lot, and look at all the things we've done to help improve the humanization of these patients, that was really important. And so we were able to start this program where anyone who had a loved one they couldn't see who they wanted to could send in my social worker photos or letters that the nurse would read to them. We'd put up the photos in the room. We arranged some patient families to stand outside, and we would get the patient to the window if we could. They would have signs, ways to have connection, because this is such a period of disconnect and so difficult. Like I can't even imagine what it's like to bring a loved one to the hospital who needs a little more oxygen, and then the next time you see them, you're maybe coming in to help accompany them as they're taken off the ventilator. I mean, these are horrific situations. And so any way that we can continue to say that this is more than this patient behind this wall that none of us can cross, but this is Bill and he loves fishing, and this is the fish he caught last month, and this is his family, and these are his grandkids, and this is all that's going on in his life, and put that up. And I said to the nurse in the ICU on rounds, just share a little bit about Bill. Like, everyone needs to know about him, because it's very important, because that's our job, is to really show it's I think in palliative care, like, the person behind the disease, and to continue to try to make sure that their values and beliefs are being lived out in their healthcare. And so we creatively tried to communicate with families as much as we could. Our team got a conference room in the hospital where we could all sit at a distance from each other and have a family on a video conference or a audio conference. The videos were sort of hard. A lot of our patients didn't maybe have the best tech savviness or the ability, so the majority have been on audio, unfortunately, because I do think that the video allows more of a ability to trust, because they can see us, but it's still been good to ask about who the patient is and get them to share stories with us and let us know how they're doing, and working on care for the caregivers, care for the families, because it's so challenging at this time. And so these are all creative things that we did, trying to accompany these families and be with them and sort of gradually support them if things were going the wrong way, to a level of acceptance of what was happening. And so it continues to be hard. And as I give this talk, I speak with a lot of humility, because I know that there's been a lot of times I've not done it the best, or continue to grow and learn. And so I really appreciate if anyone has advice on what they've done to best communicate with these families during these difficult times, because it continues to be very, very challenging. So on a personal level, I think that I really tried to reconnect with the roots of why I went into medicine. And although this is such a difficult time, I think about how grateful I am to be able to make a direct impact during this very challenging time. The gift of being able to go to work, the gift of being able to be healthy and to serve others, to be able to communicate to families during such a difficult time of what's going on, and to support them along with my team. And I try to engage gratitude, to think about how grateful I am to be able to do this work. And also, I try to think and have gratitude for all those I work with, too. And I think as a palliative care team, we are sort of the eyes on the ground in the hospital of who's struggling. You know, that nurse is really struggling, or that doctor has just really been not doing great. And to kind of have a tenderness and reach out to our staff colleagues and to say, this is really hard. How are you doing? I've had some nurses, just when I ask them that, they kind of break down, and this is hard on everyone. And just to kind of realize that with a mercy of how we interact with others at work, and to know that we're not going to be perfect. We're going to do the best we can, but this is super tough. And during that period when I had so much compassion fatigue, it was almost like a miracle. But one day in our palliative team meeting, the door opened and all these staff members came in, and they had a cake, and they recognized our team as like employees of the month at the hospital. And they probably knew we were struggling with how we were trying to support these families. But it was very, very meaningful to me. It was very touching to be thanked by the hospital. And so often I think our job is thankless. No one knows what we're doing. No one knows the gravity of the emotional heaviness of what we deal with on a daily basis. But that little glimpse kind of got me through more. We've really tried to take a breather before we do our meetings, before we do our phone calls. We try to entrust things to God. We have our chaplain lead us in a prayer before the calls, and oftentimes in the midst of the call as well with the family members. Something else that I think has really helped me is advocating for my needs to the leadership at the hospital. So during that period when the patients were not getting phone calls to their families for about 10 days in our ICU, I had like 4 consults one day with different families, and it was very, very hard, because my role is not to be the bearer of all diagnostic and prognostic information. My role is to help support the families through receiving that and helping to guide them with that. And so it was very important that I didn't take all that on. And so to set a boundary, and so I called our ICU docs, and I called the head of our hospitalist and I said, someone else needs to be giving regular updates. What I've been doing more recently is actually having the intensivist with me on a call to some of these families, and I work around their schedule and I try to support them and say, this is so hard, yet I'm here with you. And you can give the medical update, and even if you're very busy, I have them just come to the beginning of the meeting and then I stay and support the family. There's a couple of my colleagues who were quite nervous about this, so I just kind of made cue cards. We were on an audio call, so the family was not aware of this, but I kind of wrote them lines and I said, say this and say this. It'll sound really like, this is what they would need to hear. And having it come from the ICU doctor themselves was very helpful, because I think we need to have present a united front and not have an environment where there could be an ease for splitting behavior, where palliative care is bad, ICU is good. I'm sure we've all been in scenarios like that, and they're just devastating. There were a couple of COVID families who fired the palliative team, and that broke my heart, because why would you fire your support team, the people that are just here to help you? But there was such a level of, they felt, I don't know, threatened or in denial or just anxious about what was happening, that they did not want us to be involved. And so all of that were things that I was able to improve a lot just by sharing my moral distress with those of leadership. And they really responded, because they know they don't want me to quit or not be involved. They want me to help. They want the palliative care team. They see our value. And so they they were very gracious on the whole to work with me on that and setting new standards for how we would communicate. And then on a personal level, I think taking some time off has been very good, bits and pieces when I can, getting away for a few days just really can reset you. Taking time outside of work to do normal things, to where one of the things I did was, since I can't host parties anymore, I started a bike club where every Tuesday night we bike out a different bike path around Denver and then tailgate at a park. And I email friends and we just go, and it's something I look forward to. I'm still able to host or bake cookies for that, but I'm not putting anyone at risk. And it's something just very enjoyable, and you have to be creative. You have to figure out things that help you to recharge and refuel, because this work is so important to keep doing. So when I think about what could have gone better, what I would do differently, how I would readjust along the way, there's a lot of things. I think I had to get a crash course in telecommunication. Those are things that I'm doing a lot better than I didn't realize at the beginning. I think continuing to work at advancing video conferencing whenever I can to families, because that, I think, is the more personal we can get it, the better. I think continuing to really have strong communication. Anytime that I have a meeting, I make sure I reach out to the nurse, I reach out to the doc, I put a note in the chart where we're having a meeting, trying to include everyone, going above and beyond to really make sure everyone's on the same page. There's been times that I just have to keep advocating when I see that there's something going wrong, not be afraid to take it up the chain quickly. We have an incident command number that I can call that helps with COVID-19 guidelines. We've had a lot of inconsistencies at times with visitor restrictions. They'll say that the guideline is like one person per day, but then we will have someone sneak up to a couple other people down the back stairwell. And so it makes me look like a bad guy when I've tried to follow the restriction. So these inconsistencies can lead to a lot of distress and emotional issues among the patients we care for. So I think just really trying to work with consistency of education and the guidelines. I think working hard to really not attach to the outcome of the cases of these patients, because it is so easy to do that and to say, this is what should happen. And I think this is just a rule for palliative care in general. Trying to do our best we can, and knowing that every outcome may not be what we think is best, but to continue to accompany and love those people as best we can. Things that I wish my hospital would have done is to have some sort of memorial service, even for the staff, that we couldn't have any families come, but just to think about how difficult this was for caring for these patients, some of whom died after we cared for them for like a month, and to have space for the caregivers, like the nurses and the respiratory therapists, and all those different levels, our janitorial staff, our docs, to have a place to really think about what they did and how beautiful it was, but the loss of these patients. And I kind of worry that we have never done that and never taken a step to do that. So that's something I'll continue to advocate for. And then one thing that has really helped me as I've sort of had my own, as I've experienced this personally, I read a really good book called He Leadeth Me, and it was by a Jesuit priest, Walter Chiswick, who was arrested for being a Vatican spy during World War II in Russia. He wasn't. He was a parish priest in Poland at the time, but he was put in solitary confinement for 5 years, followed by sentenced to 15 years at a Siberian work camp. And how he lived his faith through those difficulties, how he continued to love others and to serve when he had so many things against him and so many limitations, it really put things in perspective for me as I continue to give the best care possible. Know there's the limitations right now, but to be grateful for this opportunity to continue to serve. And so as far as takeaways go, I just think of ways that we can continue to deepen our connection to our professional vocational calling. Because so many of us in palliative medicine, this is not a job. This is truly a calling to love and serve others, and this calling to be in healthcare. And so I think to help decrease our moral distress that we see is anticipating issues that may happen and not being afraid to advocate, to bring these issues up to your administration, to bring these issues up to leadership, to be creative. Might as well try. Our whole campaign of getting photos and letters in was really beautiful, and the families feel like they're doing something, and they're being able to. My social worker gets a lot of emails, but it's very beautiful to see how they're able to connect during this time of so many limitations, and not being afraid that when you see an issue arise, to make it known. I think that will help your moral distress when you're able to share that, and to recognize that we're in this for the long game. To recognize when you start feeling low, when you start feeling like you're not able to give that authentic empathy that you know you have, when you may have compassion fatigue, to take a break, to take a reset. Sometimes my team will just say, okay, we're going to just take a walk, or we're going to go sit in this one waiting room that has all these recliners, and we're going to put our feet up for a minute, or we're going to go down and just get coffee for a little bit and talk about how difficult this is, and what we truly, to reconnect with the reasons why we do this work. So I just encourage you to know palliative care is so important right now, and you're still making a difference despite all these limitations, despite how hard it is in the hospital right now, despite all these barriers. I really feel that our work is so valuable, and so I encourage you to not be discouraged, but to keep your faith, and to keep loving these people, and to take breaks when you need to, but to know that the work you do each day, we may never get recognized for it, but it's truly the beauty of healthcare, the art, and of what we do. So that's all I have for you. Thank you so much for listening, and really appreciate any questions or comments you have.
Thank you so much, Dr. Rodden, especially for those final words of encouragement and strength, really, for so many of us. I think the fatigue is what we're hearing from many of our members at member ministries that are now in months, who knows what months, how many months they've been going on this. And so it's very lovely encouragement to all of us. And thanks for covering so much of the creative ways you address the medical issues and the personal issues in a very condensed amount of time. And that means that to all of you participating, we do have some time left, extra time, to address your questions, comments. Feel free, Dr. Rodden would love to hear also from any of you who have found creative strategies to address the issues that they were also facing, and I'm sure many of you are also facing. Type those in the chat box too, and we will share those here now and potentially tomorrow in the follow-up email with the link to the recording. So I'm going to begin. There are several questions about creative ways to handle the isolation. I think the questions address the isolation both on, of course, the patient side and family side, but as you told so poignantly about your social worker who sat vigil outside of the patient room, that is another form of isolation that is part of this pandemic. And you mentioned briefly and kind of went over it, things you were doing with photos, letters, up to windows, all the things that you are doing to humanize. Could you just give a little bit more detail and flesh those out?
Sure. And another thing I didn't mention so far is that we actually got some tablets. I think a lot of hospitals may have these, but we got these set up with a video conferencing platform so that we can access the nurse at the bedside in the ICU can go into the room and show the families about what their patient is connected to, what the ventilator looks like, what prone positioning looks like, doing a lot of education there. And if the patient is able to speak or communicate themselves, they can actually do calls and have the tablet there, and that sort of video connection with the outside world has been very good. So that took a few weeks to get in place at our hospital, but I think that's been a really good thing. So a lot of times when I call families, I'll say, have you been able to see your loved one? And they won't even have known about it. What breaks my heart is they don't know. And so I think there's an art to when palliative care gets involved in some of these cases. I think sometimes if I get involved too early, families get very scared and worried because of what they associate with palliative care. And I try to normalize that too and say, we're the support team that is connecting for families to help them during this time. And so I just normalize it and I say like, oh, I'm on pretty much everyone in the ICU and your loved one's in the ICU. So the doctor's asked me to check in. How are you doing? Do you know about sending photos in? Do you know about talking over the Zoom? Do you know about the nurse can hold the phone up to their ear? Do you know about ways to write letters? And so that has been helpful, I think, that, and sometimes I don't see them, talk to them again for a couple of weeks, if they're getting care. And I realize they have goals that are very disease directed. So just very individualized. But, if there's kids involved, the social worker tries to somehow reach out to the kids, even on talking with them on a video chat. We're just pulling out any creative way we can. I know some doctors have been meeting like in the parking lot outside. Some palliative teams may have done that. We haven't really started that yet. I think, especially for our COVID families, they're not really supposed to be out and about because they are assumed to have COVID-19 as well. So a lot of them are in their own restrictions. So it's really tough.
And one of our participants, thanks for that, just chimed in and said, that they have found using the video feature, the tablets, although it is more cumbersome, and like you mentioned earlier, technical difficulties can arrive, just a lot more humanizing. It goes a long, long way. And especially what you mentioned earlier, the trust, establishing trust. And along that note, another question, we have several on this theme, is trust goes so many different ways, between the patient family and the care team, between the palliative care team and the intensivist team. This listener is asking if you could address strategies, ways to frame the situation where the intensivist team and the palliative care team are not communicating well, are not on the same page, possibly pulling in different directions.
That's super hard. I think that generally when I get involved, and typically it's the intensivist who adds me to a patient's care team, I ask them what they're hopeful for me to cover. So I think I frame my whole interaction. Of course, my goal will be the same, to understand the patient's values and who they are and help translate that into their healthcare. But in the meantime, if I know that the intensivist has a really strong vision that he's going to get this patient better, and he wants to be caring for this patient on the long haul, or, it kind of can color, kind of helps me as I frame things to the family. So I'm not presenting a totally different perspective. And honestly, that's why I started really requesting as much as possible to get someone from the intensivist team on my call and in my meeting. And that has really decreased the moral distress of my team, because there's nothing worse than being sort of demonized as that they might be like, oh, I don't like that Dr. Rodden. She's just negative. Because I think initially when I was following these patients for several weeks, what I was doing with my first call was just building rapport and learning about the patient, if they had had previous advanced directives, if they had ever communicated what they thought about the idea of long-term life support. Then my second call, which was approximately a week later, usually it seemed, I would maybe bring up resuscitation status if they, and this was again if they were still poorly or hadn't improved. And then it would be like the third call, which usually was around the 14-day mark or so of intubation, if I was consulted right at the beginning initially, I'd be talking about tracheostomy and long-term ventilation. And so those were hard because the families then associate every conversation with like something bad and, just a loss or something. And so I don't think that's the best way to handle it. And I don't think that all of those big care decisions should be put on the palliative care shoulders alone. I think that we need to support the primary team when you have these very high emotional cases. And when we had one family, they were literally sitting in their car in the parking lot 24/7, like sitting there and rotating out and like looking at the hospital and like buying the nurses food every shift and feeling, and they would always say, wasn't that food delicious that we gave you? Like kind of like a bribe or something, like a threat that we needed to get better care. And this patient, I mean, she just, we almost had to get an ethics consultation for non-beneficial care because of how things just kept decompensating, and they wouldn't understand or think about anything less than the highest aggressive disease focused care. And like I mentioned, I think that a lot of these families have never been around critical illness before. They may have never been in an ICU. They've never been, like, it's so different than my patients I'll see for a COPD exacerbation. This is their 6th admission in a year. They know the drill. They understand all these symptoms. Or my patients with cancer relapse or something. This is so, they don't know. They don't know what's happening, and they don't really trust the expertise of us in healthcare sometimes. And so they would say, well, I saw on the news this happened, and I saw a patient who was intubated for 80 days, and then he walked out. And I would see the news sometimes and just be mad because I'm like, that's not what it's like. And this is what's being represented. And so we had to break through a lot of those barriers and just to say, I acknowledge this is what you're seeing, but this is what we understand about your loved one in this scenario. So, yeah.
Mm-hmm. So helpful. So many challenges on so many different fronts. There's a couple questions too, kind of following from that, specifically with that family you mentioned. We tend to remember the most complicated or challenging patient or family situations. And several of our audience members are asking about those types of situations to see if you have any other insights. For example, maybe the person that is sick with COVID and or dying might be on the younger end of the age spectrum, or there might be multiple family members who are sick and or hospitalized at the same time. Not knowing whether or not that was your exact experience, but just if you have any words of encouragement or advice or guidance for those extra, when the suffering seems additionally heightened.
I think that ideally, like I mentioned, removing yourself as a palliative team in these difficult cases from the prognostic and diagnostic role, and really just focusing on care of the loved ones, because they're suffering so much and they may feel so overwhelmed, and their feelings of overwhelming fear is manifesting in pushing back on the team, not trusting, anger, and sadness, and whatever sort of emotional response they're having, trying to have a tenderness for that. And so sometimes what we would do is I'm like, tell my team, we're just going to talk about them and how they're doing. and maybe tell us just about their loved one's life, but we're not going to really go into anything, at least at the first meeting or maybe the second meeting. And we just say, are you eating enough? Are you drinking? What do you think could be better? What in your opinion could be done differently? Trying to give them as much. They feel so like they have no control. I mean, a lot of us feel this way, I think, with COVID-19, that we're totally out of control because we don't understand it. And we see some patients that get sick and we're like, why did that person get sick? And their loved one, what I've seen too, which is super challenging in these dynamics, and I think leads these families to cling to aggressive care sometimes, which beyond what we in healthcare maybe think is reasonable, is that they feel guilt that they caused this. So I had a gentleman in his 90s that died in March who the son felt, he knew he gave it up to his dad. He was going to help his dad with chores around the house. And then we have another couple where the wife was here for so long. She ultimately was able to get a tracheostomy, but it was touch and go for so long. And the husband had COVID, got it from work, and he barely had symptoms. But his wife ends up in our ICU. And to feel like he was the person that killed her, I mean, that's a whole nother level of complexity to these situations. And so for them to feel like I keep saying giving up, and I try to frame the ventilator as a bridge. I say, this is not meant to be a long-term solution. The ventilator is a form of life support that is meant to help your loved one get from point A to point B. Sometimes point B doesn't seem like it's going to be realistic or a fair option. Like it doesn't seem like we're going to actually get there. And I'm so sorry that it doesn't look like that. Helping them get to understand that. You just have to be gentle and you have to be slow. And I think don't be aggressive. Be very, for me, like I'll have my social worker call and set some feelers out. Like, do they think it'd be helpful to talk? And if they really don't, then I'm like, okay, we'll just stay out for a few days. And if something worse happens, maybe we'll chime back in, or how are you doing? Or we just wanted to see, or it was your loved one's birthday, or it was someone's anniversary. Like, how are you doing right now? Or that kind of thing can be helpful, just to know like we're on their team as much as possible from the get-go. To say, we're your support in your corner. We're rooting for you. We're rooting for your loved one. We're hoping for the very best. Like we always say, we hope for the best, prepare for the worst. But sometimes focusing on we don't want to give a rosy-colored picture, but sometimes I just sort of gradually go into these challenging conversations with just a little slower pace than I normally would, because I know they're going to be with me for potentially a while. So.
Thank you. That is really, really helpful. We wish we could make it all better, but the reality is right now we can't. Maybe we always can't make it all better, but this really brings it front and center for us, the limits of our own human abilities. And on that note, we have several folks really resonating with what you were talking about this is a moment where you, I'm gathering spiritually and from your own faith convictions, and just in general, kind of existentially as a human being, you have found this to be an opportunity to reconnect with your own meaning and purpose and vocation and calling. Could you say a little bit more about that?
Sure. Well, I didn't always do it very well. I think that they have a couple of handouts attached to this webinar. That I had one that I wrote for the Catholic Medical Association early on, like in March. And I looked at that again in early May, and I thought, who is that person? She has it together, and I think that's obnoxious. I don't feel like that. I'm in a very different place, and that was hard to see. It was hard to see how, but it was also how much I've been affected by the challenges of this. But I think it was also good because I had to realize that I couldn't be self-reliant. I had to realize I needed to make changes to ask others for help and be creative in new ways to continue to find meaning to refuel, to be gentle with myself, because I think that healthcare hero mentality is out there. And I actually had a discussion group with friends on what is the meaning of a hero today, because it's different. We're using that word so much, and to realize that like everyone's affected by this, and it's okay to struggle at times, and to see how little control we all have, and we're all in this together. But it's been just a process, I think, of making time for, and I'm able now to go back to Mass in Colorado, so that's been really good, and taking time for prayer, taking time to do things with friends that are super not related to COVID, things that seem normal. Like I went camping one weekend, and that was so good. I just think that all of us felt a relief, like we're just here at the campsite having a little bonfire, and this is just normal, and to remember and to have a hope, to not lose hope, because I think it's in those moments of, like for me, when it was sort of a trigger when things would get canceled that I looked forward to, then I would just lead to more despair, and to say, and what I've really seen in my prayers is this feeling of surrender, of trust, and of hope, and to continue that, because I think our faith is rooted in hope. Like if we didn't have the Christian hope, and if we didn't have, how could we do this work? If we didn't have hope for our patients, if we didn't, hope that there was some sort of thing greater than just their suffering and their current situation, then I don't think we would be able to do this work at all. We would all be super depressed. And to say that even though I'm little and I don't have much to offer, or I feel like I'm not doing very much, and I feel like COVID is this huge insurmountable thing that I'm coming up against, how, Lord, can I love this person in front of me? And how can I receive your love today? Lord, let me see your love today. Show that to me, surprise me, give me evidence of your love in my life, and to try to recognize that in the midst of all these challenges, taking time to, whether it's on the way to work, whether it's after work, whether it's in the middle of the day, whether it's with your team, just to take a little moment to center of why I do this, and then to know that I'm not just a palliative doctor, I'm a person, and all the sides of me need to stay nourished. And so outside of work, I'm not just the palliative doctor, I'm the person who runs Bike Club, and I love that. Or I'm the person who, wants to, go on a camping trip, or I'm the person, I'm the daughter, to continue those relationships that are life-giving and in your life, to help boost your spirits in any ways that you can. And for me, like hearkening back to other experiences in my life that have been difficult, and what worked then, what can I do again? What do I need to build up my armor thicker to be able to get through this? And to just take a day at a time, and know that I might fail today, but I have tomorrow. And so to keep trying each day.
Mm-hmm. Thank you. And we have several people. This will be our end point here, but I did just want to share with you and everyone that we have several participants who have typed not a question into the question box, but just a great thank you and appreciation for your honesty and openness and vulnerability, in that, like you were just saying, you might feel like you need to put on your armor when you work every day, but thank you so much for taking off your armor and sharing how you're really feeling, and how this is a struggle for you. I think so many are feeling that, and we don't necessarily have a place to share and say that. So thank you for modeling that vulnerability. And thank you everyone for joining us today on this webinar. And Dr. Rodden, I'd like to encourage you at the end, as we close the webinar, the feedback survey will pop up on your screen. If you could take a minute or two to complete it for us. We shared those comments with our presenters, We use those ourselves to plan future webinars. For those of you whose questions are still in the queue and we didn't get to them, as you'll see, Dr. Rodden has generously shared her contact information. Feel free to reach out to her and continue the dialogue. Our next webinar will be not next month, it will be later this month, continuing in this series of navigating new realities. And we are going to be hearing from a team at Bon Secours, Palliative Care, Dr. Kara Jennings, Dr. Mark Flickinger, and their social worker, Ann Hardy. And they are going to be talking about something that you brought up, Dr. Rodden, and they're going to go into a bit more depth, is the importance of these new collaborations that they developed as a way of responding to the COVID pandemic as they experienced it in their ministry. Registration for that webinar is now open on our website. And today's webinar was recorded. You will receive an email tomorrow with the link to the access to the recording to listen to on demand. And thank you, Dr. Rodden, again. Thank you, everyone, and have a good day.